Hello everyone, I'm Anas Al-Ubaidi, and the topic for this session or the topic of this lecture is about recognizing and documenting cardiac pathologies and pulmonary function test interpretation. And this lecture or this session within chapter 28 of Review of Cardiology and Pulmonology Scribing within the Certified Medical Administrative Assistant course program by ACMSO. Introduction. Recognizing and documenting cardiac pathologies and pulmonary function test interpretation is a crucial skill set for medical scribes operating in cardiology and pulmonology focused clinical practices. These areas sit at the intersection of two critical bodily systems, the cardiovascular and respiratory systems, where coordinated care is imperative. The accurate recognition and documentation of cardiac pathologies, coupled with the ability to interpret pulmonary function tests, PFTs for short, directly impact patient safety, diagnostic accuracy, and treatment efficacy, emphasizing the significance of precision, attention to detail, and clinical awareness. For advanced medical scribes, mastering these competencies is essential for supporting healthcare providers and enhancing patient care. Cardiac pathologies present a broad spectrum of disorders, ranging from acute emergencies such as myocardial infarctions and arrhythmias to chronic conditions like congestive heart failure, CHF for short, and valvular diseases. Documenting these conditions goes well beyond transcribing symptoms. It requires a deep understanding of disease progression, diagnostic markers, and therapeutic interventions. Key indicators such as ejection fraction (EF) for short from echocardiograms, electrocardiogram (ECG) or EKG for short findings of atrial fibrillation or AFib or troponin values in suspected heart attacks must be accurately captured alongside the patient's history and presenting complaints. Missteps in this documentation could result in misdiagnoses or misdiagnosis, delays in intervention, or suboptimal care plans, underscoring the heavy responsibility scribes carry in mitigating risks through their records. Pulmonary function test interpretation, while distinct, closely complements cardiac documentation. PFTs, pulmonary function tests, evaluate the function and capacity of the respiratory system, measuring metrics like forced expiratory volume, FIV1, forced vital capacity, FVC, and diffusion capacity, DLCO. These values help diagnose and differentiate between obstructive lung diseases like asthma and chronic obstructive pulmonary diseases, COPD, and restrictive conditions such as interstitial lung disease or pulmonary fibrosis. Scribes documenting these results must have foundational knowledge to translate raw data into meaningful chart entries, particularly in complex cases involving comorbidities like cardiopulmonary overlap syndrome. Misinterpreted or incomplete documentation could compromise adherence to diagnostic algorithms, leading clinicians astray from optimal therapy routes. One of the primary challenges in documenting cardiac and pulmonary conditions is the complexity and overlap in their symptomatology. Shared presentations such as dyspnea, chest discomfort, or fatigue require careful differentiation through a history taking, physical exam or examination, and additional diagnostic tools. For instance, it's critical for scribes to record whether dyspnea correlates with physical exertion for suspected heart failure versus airway obstruction, typically of asthma exacerbations. Capturing symptoms with precise descriptors, relevant timelines, and context ensures that the nuances of the clinical picture are retained, enabling accurate diagnoses and tailored management. The role of documentation facilitating continuity of care and interdisciplinary collaboration cannot be overstated in these specialties. Cardiology and pulmonology often involve interactions with primary care physicians, intensive visits, intense vists, intensivists, cardiothoracic surgeons, respiratory therapists, and rehabilitation teams. Effective documentation serves as the backbone of communication, ensuring that every specialist touching the patient's case operates from the same understanding. Whether tracking trends in pulmonary function over months or monitoring post cardiac intervention recovery markers. Scribes also support transparency and compliance, ensuring notes are accessible for audits, second opinions, or transitions between inpatient and outpatient settings. Furthermore, as healthcare increasingly leans on templated documentation for efficiency, advanced scribes must balance usability with uniqueness, recognizing when standardized formats might miss patient specific nuances that impact outcomes. As for instance, while PFT, pulmonary function test interpretative templates provide a framework for results documentation, it falls on scribes to ensure that critical findings like a sudden drop in DILCO, DLCO, or worsening obstructive patterns are appropriately emphasized for urgent provider review. Similarly, in cardiac cases, templates summarizing cath lab procedures should align procedural findings, as for example, severe LAD stenosis, with subsequent therapeutic plans, for example, stenting or bypass. Key points: symptom documentation in cardiology and pulmonology. Symptoms related to cardiac and pulmonary pathologies often overlap, requiring detailed and precise documentation to aid in accurate diagnosis. Recognizing nuances in symptom presentation is critical. Documenting chest pain. Key requirements record onset, location, nature, duration, and exacerbating/relieving factors. Distinguish between cardiac, for example, angina, and non-cardiac causes, for example, musculoskeletal. Example, patient reports sternal chest pain lasting 15 minutes, described as pressure radiating to the left arm, worse with exertion and relieved by rest. But here we have relevance aids in differentiating between stable angina, myocardial infarction MI, or non-cardiac etiologies like GERD, gastroesophageal reflux disease. Recording dyspnea focus here not circumstances of onset, triggers, and progression. Specify if it correlates with exertion, positional changes, or paroxysmal nocturnal occurrences. Example reports shortness of breath when climbing stairs worsened over 4 weeks, associated with orthopnea and nocturnal wakening. The importance here differentiates heart failure from obstructive conditions like COPD or interstitial lung disease. And here is a summarized diagram summarizing comprehensive chest pain documentation. Documenting fatigue approach include questions about severity, interference with daily activities, and exacerbation patterns. For example, patient states feeling fatigued after minimal exertion, unable to perform routine tasks associated with palpitations. Impact here points toward conditions like anemia, atrial fibrillation, AFib, or chronic pulmonary disease. Cover and sputum production details to note duration, quality, quantity, and associated symptoms like hemoptysis or fever. Example, persistent cough producing white sputum for over 2 months, recently blood tinged. Significance here helps differentiate chronic bronchitis, pulmonary embolism, or malignancy. Edema and weight gain, critical to include onset, response to diuretic therapy, and association with other symptoms like ascites. Example reports gaining 5 pounds in 1 week with pitting edema to mid-shin and abdominal bloating. Outcome essential in diagnosing congestive heart failure, CHF, or nephrotic syndromes. And here is a diagram on patient assessment. Diagnostic standards in cardiac pathologies, accurately documenting diagnostic findings related to cardiac pathologies, provides a clear roadmap for intervention. Echocardiogram results, echo, Here are results. Key focus record ejection fraction, EF, valve function, and presence of structural abnormalities. Example, echo shows EF 30%, severe mitral regurgitation, dilated left ventricle, LV at 6.9 centimeter. Application correlates with ongoing heart failure management and surgical planning. ECG or EKG documentation here, standard fields, rhythm interpretation, ST segment changes, and any conduction delays. Example, ECG or EKG indicates atrial fibrillation or AFib with rapid ventricular response, ST depressions in lateral leads. Rule differentiates acute ischemia from arrhythmias and guides immediate management. Troponin levels in ACS, acute coronary syndrome. Usage here essential for confirming cardiac injury in acute coronary syndromes, ACS. Example, troponin 1 elevated to 10 ng per mil corresponds with 3 hours of chest pain onset. The outcome guides decisions on revascularization or medical therapy. Stress test or angiogram findings. Documentation needs here include ischemic thresholds and interventions performed. Example, positive exercise stress test with ischemia at 8 METs METS, stent placed in mid-LAD LAD. Significance provides a definitive view on personalized treatment strategy. Heart failure metrics. Parameters BNP levels, ultrasound indices, and recent exacerbation history. Example, BNP degrees from 750 pg over mil to 320 pg, 320 pg over mil over 3 weeks post diuretics. Relevance here tracks treatment success and adjusts therapy as needed. Interpretation of pulmonary function tests, PFTs. PFTs are essential for documenting pulmonary diseases. Scribes must interpret and structure their documentation clearly and concisely. Spirometry metrics, key values document FIV1, forced expirative volume in 1 second, and FVC, forced vital capacity. Example, FIV1 over FVC ratio reduced to 60%, consistent with obstructive lung disease. Use differentiates between obstructive, for example, COPD, and restrictive patterns. DILCO-DLCO findings, importance here, measures the diffusion capacity of carbon monoxide to assess lung parenchyma integrity. Example, DLCO reduced to 40%, suggestion of pulmonary fibrosis or emphysema. Purpose here further defines the extent of pulmonary impairment. Flow volume loops utility here and identifies airway obstructions and patterns specific to conditions like asthma. Example, a flow volume loop shows concave pattern in expiration consistent with obstructive pathology. Impact here supports diagnoses requiring specific bronchodilation trials. Reversibility testing, documentation results before and after bronchodilator administration. Example, post-bronchodilator FIV1 improved by 15%, indicating reversible obstruction, asthma. Outcome confirms reversible or irreversible mechanisms. Multi-test integration, best practice cross-reference PFT, pulmonary function test results with imaging for cohesive documentation. Example, PFT pulmonary function test shows mixed restrictive and obstructive pattern, high resolution CT pending for pulmonary fibrosis evaluation. Significance combines data for provider clarity. Handling complex cases. Patients with overlapping or ambiguous symptoms demand specific documentation strategies. Cardiopulmonary overlap syndrome focus capture interplay and differentiation of symptoms between the heart and lungs. Example, dyspnea worse with activity, BNP 800 pg over mil, FIV1 over FVC ratio at 55%, suggests comorbid CHF, congestive heart failure, and COPD, chronic obstructive pulmonary disease. Importance guides dual therapy strategies. Pulmonary embolism PE. Best practice document Wells criteria assessment along with the imaging results. Example, tachycardia noted. CT angiography shows occlusive clot in right pulmonary artery. Relevance here provides essentials for anticoagulation or thrombolysis initiation. Silent ischemia or arrhythmias. Proficiency documents subtle complaints, for example, fatigue, that trigger deeper evaluations. Example, patient denies pain but reports fatigue. ECG, EKG, or EKG shows new Q waves in anterior leads. Outcome prevents misdiagnoses leading to poor prognosis. Supporting multidisciplinary care, scribes must ensure seamless documentation for care teams spanning multiple specialties. Cardiologists, pulmonologists, coordination role here rely information between disciplines effectively. Example, pulmonology concluded interstitial lung disease as exacerbation, trigger for congestive heart failure, CHF. Diuretic dose adjusted accordingly. Value ensures collaborative therapy and avoids conflicting interventions. Pre-surgical documentation focus, not perioperative risks and diagnostics. Example, patient cleared for CABG, baseline DILCO DLCO at 75% with no restrictions for anesthesia. Impact minimizes intraoperative complications. Chronic disease management, detailing consistently track progress in long-term interventions. Example, ejection fraction EF improved by 10%, FIV1 stable at 80%, post-rehab and medication adherence. Importance builds a roadmap for sustained improvement. Summary tables. Here we have table on key elements of symptom documentation, symptom description, example, importance, risk if neglected. Symptoms, we have chest pain, dyspnea, fatigue, cough, and edema. Table on diagnostic standards for cardiac pathologies, diagnostic test, description, example, relevance, failure, impact. Diagnostic tests, we have echocardiogram, electrocardiogram, ECG, troponin levels, stress test, and BNP levels. Table on pulmonary function test documentation, PFT, pulmonary function test parameter, description, example, clinical use, risks of poor documentation, parameters FIV1 over FVC ratio, DILCO DLCO, flow volume loops, bronchodilator response, and combined interpretation. Table on managing complex cardiopulmonary cases, condition, key features, example, documentation, priority, clinical relevance. Cardiopulmonary conditions, we have cardiopulmonary overlaps, pulmonary embolism, PE, restrictive lung disease, silent cardiac ischemia, combined heart-lung surgeries. Table on supporting multidisciplinary coordination, scenario, collaborating teams, example, documentation needs, patient benefits. Scenarios, we have acute cardiac events, chronic pulmonary care, rehab and lifestyle, cancer-associated cases, and post-surgical recovery. Next, we will revise what we have covered via this lecture through some MCQs or multiple choice questions. Question 1. What is the importance of documenting the specific characteristics of chest pain, such as onset, location, triggers in cardiac cases? A, to minimize the time spent on physical examinations. P, to differentiate cardiac-related pain from non-cardiac causes. C, to avoid the need for ECG or stress test diagnostics. Or D, to prioritize recording the patient's emotional response to the condition. The answer would be B, to differentiate, as detailed documentation of chest pain characteristics help distinguish angina or a myocardial infarction MI from other conditions like GERD or musculoskeletal pain, leading to timely and accurate treatment decisions. Question 2. Which finding from an echo is most critical for documenting heart failure progression? A, increased DILCO levels. B, ejection fraction EF measurement. C, irregular breathing patterns during the test. Or D, absence of demand for diuretics. So definitely the answer here is B, the EF. An EF, ejection fraction lower than normal, indicates reduced heart function, which is essential for assessing the progression and severity of heart failure and guiding treatment plans. Question 3. Why is the FIV1 over FVC ratio crucial in pulmonary function test interpretation? A, it determines whether high-resolution CT imaging is needed. B, it identifies airflow obstructions or restrictive lung disease patterns. C. It replaces the need to document DILCO results, or D. It is unrelated to the diagnosis of chronic lung diseases. So definitely the answer is B, as it differentiates as the FIV1 over FVC ratio helps distinguish obstructive diseases like COPD and asthma from restrictive conditions, ensuring appropriate treatment strategies are documented and followed. Question 4. What is an essential consideration when documenting a case with cardiopulmonary overlap syndrome? A. Only focusing on the cardiac factors influencing the patient's condition. B. Avoiding referrals to pulmonologists to simplify documentation. C. Recording contributions from both cardiac and pulmonary systems. Or D. Using templates designed solely for respiratory conditions. Definitely the answer is C. Recording contributions from both cardiac and pulmonary systems, as cardiopulmonary overlap syndrome involves symptoms from both systems, requiring comprehensive documentation to ensure accurate diagnosis and dual-focused management plans. Question 5. What is the best practice when documenting multidisciplinary care coordination for a patient recovering from a cardiac event? A. Prioritizing limited information to avoid overwhelming other team members. B. Detailing interventions performed by each care team member. C. Generalizing recovery progress without specifics on the therapy outcomes. Or D. Avoiding documentation of follow-up recommendations. Definitely the answer is B. Detailing interventions, as thorough documentation of contributions from the multidisciplinary teams ensures cohesive care and reduces the risk of miscommunications during recovery and transition processes. And here we come to the end of this lecture. Thank you very much and goodbye.